Hi everyone, my name is Maria. I'm a master's student here at UC San Diego, and today I'm going to present on my thesis project, Cerebral Spinal Fluid Circulating Tumor Cell Analysis Informs Early Diagnosis, Prognosis, and Treatment in Leptomeningeal Metastases. So I want to take a step back and recognize that we might have different backgrounds here and expertise in different clinical areas. So I want to start by telling you a story to why I think this research is important and why I'm drawn to it. So when I started being interested in science, I told my parents that I wanted to cure cancer. And I didn't quite understand how charged that statement was back then. And although many cancers today have cures, many of them, especially related to the brain, don't. And they have extremely low survivals and or currently don't have any effective treatments. And so there's a huge road, not towards cure quite yet, but there's a lot we can do to improve the life of these patients diagnosed with cancer like this. And that's the case for leptomeningeal metastases that I'm going to be talking about today. So leptomeningeal metastases happens when tumors from other parts of the body, like the lung, metastasize to the spinal fluid. The spinal fluid is shown here in this image on the right. It is represented by the blue arrows, and it goes through and from the brain and the spinal cord. And the tumor cells, they can either be free-floating or adherent. And some primary tumors that commonly metastasize to the CSF are lung, breast, and melanoma. But there's not been a lot of studies in this condition, and because it's been growing in incidence in the past years. So the reason for that is because as treatments evolve for other types of primary tumors, patients live longer, but they're also more likely to develop metastases. And so lately, there's been a growing interest in this condition, and some clinical trials are starting to ask, what can we do to better treat it, to improve the low, median overall survival that we currently have, which is 2 to 4 months. So most of these historical controls get treated with some sort of intrathecal chemotherapy that it gets delivered directly into the spinal fluid. But as I said before, the clinical trials now are trying to see, can we add a combination of treatment, and what are other possibilities that we can do for these patients? So what happens when a patient gets diagnosed with lepto? So as I mentioned in the picture before, the CSF goes through and from the brain and the spinal cord. So depending on the tumor location, they also will present with different symptoms. So if a tumor are mostly located around the brain, they most likely will present with double vision or headache, confusion, some cognitive impairment or seizures. However, because of gravity, tumors tend to locate towards the bottom of the brain, and that's where the cranial nerves are. So there is a lot of cranial nerve related symptoms like difficulty swallowing, facial weakness, and hearing loss. And if the tumors are located primarily in the spine, they could present with limb weakness, sensory loss, numbness, bowel or bladder issues. And lastly, there's some inflammatory symptoms like nausea, vomiting, and positional headache. But the fact is that patients that get diagnosed with this condition, they can have very advanced disease. And it's important that we can not only manage these symptoms, but potentially improve their overall survival. So how can we do that? My study is focused on this multimodal treatment approach that we apply here at UCSD. Because there's a lot of components to it, I'll try to go by step to somewhat make it sense. So you can see from this timeline already that it's much more aggressive than the historical single treatment approach. And the first step is a really important step, which is the diagnosis. So because it's such an aggressive cancer, the early diagnosis is really important factor. And it's also really important to have an effective diagnostic tool. So in the study, many of these patients got diagnosed with this new tool called Circulating Tumor Cell Analysis, in which you can sequence the DNA and get more information about the tumor compared to other traditional diagnostics approaches like lumbar puncture. So after they get tested, they go through radiation. And historically, there's been two types of common radiation for this condition. One is focal radiation. So it is focused on a specific part of the spinal cord or a specific part of the brain that there is a high concentration of tumors. Or whole brain radiation, which the name explains, it radiates the whole brain. And although it helped manage symptoms, it didn't really show any improved survival in previous studies. So because, as I mentioned before, the spinal fluid is floating, if there's tumor cells in a specific part of the spine and you radiate there focally, and there's any tumor cells in another part of the CSF, it will just go back there. So although it helps with the symptom management, it didn't really show any improved in survivability. However, very recently, there's been a new treatment, a new radiation, that is craniospinal radiation. And that radiation is on the whole brain and the whole spine. And the clinical trials that have looked at this shown an improved in overall survival. So some of these patients that I'm analyzing did craniospinal radiation. So after they get radiation, then they go through surgery to get placed in Ommaya reservoir, which is a reservoir that sits on top of the scalp, and it allows direct access to the spinal fluid. And that allows us to then deliver chemotherapy intrathecally. That means directly into the CSF. So as you all may know, there is a big challenge with crossing the blood-brain barrier. So being able to deliver these chemotherapies directly to the CSF presents a big advance for these patients. So after they get IT chemo, they also go through systemic chemotherapy, which is the common chemotherapy that we all know. So I kind of already touched upon it, but just to reiterate, my research question is to see if this multimodal treatment that I mentioned before, guided by this new diagnostic tool, improves the overall survival compared to historical controls. So to answer that, we collected data from 60 patients that were referred to neuro-oncology here at UCSD. And 36 of them had breast cancer as their primary tumor, 18 had lung cancer as their primary tumor, and 6 of them had other types of primary cancer like ovarian, neuroendocrine, endometrial, and later I'll explain why I chose to group them all together. I analyzed my data using RStudio, and I ran Kaplan-Meier survival analysis to estimate the survival over time. And I also did Cox proportional hazards to help identify which variables significantly influence survival, and log-rank tests to be able to compare the survival curves from different groups. And here's my results. I wanted to start from the beginning, which is diagnosis. So an important part of this study is to see if the circulating tumor cell is a better diagnostic tool. And we found that the CTC analysis showed a higher sensitivity with around 85% compared to the traditional cytology, which is lumbar puncture, with around 60%, which is pretty low. And not only it shows an improved sensitivity, which is really important, but we can get the early diagnosis and we're able to get more information about the tumor profile, and that will guide the treatment choices for each individual patient. So before I show my statistical results, I want to show a more illustrative effect of the treatment. The tumors are indicated by this arrow here. And you can see this white coating that represents the tumor before treatment, and in that image, post-treatment. And this is a brain MRI. And now with spine MRI, it's the same. It's shown by the circle, the spinal cord before treatment, and here on the right, post-treatment. And now for my statistical analysis. So first, I wanted to show the overall survival for all patients and compare that to historical controls. So I'm currently working on actually getting the data from these historical controls, the studies, so I'm able to plot them in the same graph. But for now, I placed this yellow line here that represents the historical controls from around 2 to 4 months. And you can see that most of my patients lived longer than the historical controls, which is great. The median overall survival was 13 months, which is significantly higher than the historical controls. And around 70% of the patients lived up to 6 months, which is higher than the historical controls as well. And some patients even living up to 79 months, and that patient is censored, so they're still alive. So this is pretty amazing. And afterwards, I wanted to see what kind of factors might influence the survival. So I started with the most obvious one, which is the primary cancer pathology. And we have the same here on the x-axis, the time in months, and on the y-axis, their survival probabilities in the Kaplan-Meier curves. And the reason I added this graph on the left is to illustrate why I chose to group all the other patients into one group other. Although it's not ideal because they are pretty different from each other, statistically, there was too little patients in some of the groups, like just 1 or 2, and so I grouped all the others together. And what you can take away from this is that their primary cancer pathology will impact their overall survival, which is expected as these primary cancers are very genetically different from each other. So I mentioned with the CTC analysis that we were able to get information about the tumor molecular profile. So what does that mean? So tumors can present with genetic mutations, and this information is important because not only different genetic mutations present differently in terms of the disease itself, but also if the type of treatment that we have for each of these groups. So on the left here, it's a Kaplan-Meier curve for patients with breast cancer that had HER2 positive mutation versus HER2 negative mutation. And you can see that there is a trend towards higher survival in the patients with HER2 positive mutation. And that could be not only because they're genetically distinct, but also because we have a targeted chemotherapy for HER2 mutation, which is Herceptin. So these patients on the top line got Herceptin as their targeted therapy. However, on the graph on the right, for EGFR mutation in lung cancer patients, there was not a really significant difference between the groups in terms of their survival. The next variable that I was interested in looking is the Karnofsky performance status, which is an approximation by the doctor of the physical state a patient is in initial consult. So usually from 100 to 80, they're able to work and carry on with normal daily activities. But from 70 to 50, usually they can still live at home, but they're unable to work and they need some assistance in some of their personal needs. From 40 to 0, they usually need hospital or some sort of institutional care. And their disease may be progressing very, very quickly. And we could see here that there is a significant association between the overall survival and the primary cancer and the Karnofsky performance score. And in the plot on the right, I just showed that stratified by the primary cancers. So a lower Karnofsky score meant that they have a lower survival probability, and a higher Karnofsky score mean a higher survival probability. And And lastly, I want to talk about the craniospinal radiation patients versus the patients that did not get craniospinal radiation. So as I mentioned before, previously patients used to get whole brain radiation or focal radiation, which wasn't really effective for their overall survival. But recently, there's been craniospinal radiation, but I mean recently, because only 8 of my patients were able to get it, and that's why my curve is stopped in the middle, because these patients were diagnosed recently and they were able to get craniospinal radiation, but most of them are censored because they're still alive. So there's a need for future research looking at craniospinal radiation, which in fact there will be soon at UCSD. One of the future directions of this study is that now we're going to do a clinical trial for craniospinal radiation. So we're going to really be able to understand more of the impact on survival. So some of the limitations of my study, some of them I already mentioned, is I had a relatively low N, and that mostly showed itself when I tried to divide by subgroups. So looking at a specific mutation at a specific subtype of primary cancer, that's when I had very little amount of patients. So that really made it difficult to account for the heterogeneity of the disease with the different pathologies and the different molecular subtypes. And also, there's been very recent advances that impact survival, like I mentioned with the craniospinal radiation. So we need to keep following up with these patients to really understand the impact on survival. But despite these limitations, from this study, we're able to see that the early detection and the diagnosis with the CTC and the multimodal treatment provided improved overall survival when compared to historical controls. But we need to do larger retrospective and prospective studies, which we will, to really characterize by tumor subtype, primary cancer pathology, and molecular profile. And I want to finish with another story. So there was one patient that did not get included in the study because they chose not to undergo treatment. And the reason for that is because they looked up online and saw previous studies, and they saw that the median overall survival for their condition was up to 3 to 4 months. And so they saw that they had a low chance of survival, and they chose not to go through treatment. So with the study, I'm hoping that we can educate patients and oncologists that there is a possibility for better outcomes, and I think this is a good start to that. Thank you.